Welcome to this educational program, and congratulations on taking an active role in your healthcare. It is our sincere hope that this program will enhance the discussions between you and your physician regarding your surgery. This module provides a brief overview of vaginal hysterectomy, including why it is done, what to expect in hospital, expected outcomes, and potential surgical risks. This information is taken from a recent review of the medical literature and attempts to be as transparent and comprehensive as possible. However, the figures quoted may not necessarily reflect the experience of your surgeon. A more detailed background discussion of conditions which might require hysterectomy can be found in separate modules. Hysterectomy means removal of the uterus. Vaginal hysterectomy simply means that the hysterectomy is performed through the vagina. In almost all cases, the cervix is removed along with the body of the uterus. The ovaries are usually seen during vaginal hysterectomy, but may often be difficult to reach. As a result, many surgeons would leave them in place if they appear normal. For this reason, a hysterectomy primarily performed for problems with the ovaries is almost always done abdominally. Before going into more details about the procedure, let us first review some anatomy which is important to the discussion. The uterus is located at the top of the vagina. It is divided into the body, lined by endometrium, and the cervix, which is the lower part which dilates during labor and delivery. It can be seen here that the uterus is anatomically very close to the bladder and the rectum. Care must be taken not to injure these nearby structures during hysterectomy. The term total hysterectomy is commonly misunderstood. Most people take it to mean that the uterus, cervix, and the ovaries were removed, thus the common comment that everything was removed. The term total hysterectomy, however, only means that the body of the uterus, as well as the cervix, were removed. It says nothing of the ovaries. If the ovaries were removed, it is usually mentioned as a separate procedure, called a bilateral salpingo-oophorectomy, or BSO. The term total is not commonly used for vaginal hysterectomy. This is because it is extremely uncommon to do a vaginal hysterectomy and not remove the cervix. On the contrary, occasionally during an abdominal hysterectomy, the cervix is left behind, and some will refer to this as a partial hysterectomy. This will be discussed in a separate module. Leaving or removing ovaries during any hysterectomy is always something that requires a discussion, regardless of how the hysterectomy is done. If the reason for doing the hysterectomy involves the ovaries as well, for instance in the case of a cyst or a tumor, then the operation will most likely be performed abdominally so that the surgeon can clearly inspect the pelvis and abdominal cavity for disease. This is less feasible during the vaginal approach. Vaginal hysterectomy, then, is only done when the ovaries are considered to be normal, and the question becomes one of whether or not to remove these normal ovaries. Traditionally, removal of the ovaries, or oophorectomy, has been offered to women undergoing hysterectomy after age 45. This is more commonly offered during abdominal hysterectomy than vaginal hysterectomy, since it is much easier to do abdominally. There are two schools of thought regarding this. The oncology school of thought, which deals with cancer, and the endocrinology school of thought, which concerns hormone balance. The oncology school of thought is that removal of the ovaries at the time of hysterectomy is preferred, as it would prevent the possibility of ovarian cancer later on. Women have a 1 in 70 chance of developing ovarian cancer in their lifetime if they don't have a family history. This rises with an immediate family history of certain cancers, including ovary, breast, and colon cancer. It has been estimated that one case of ovarian cancer will be avoided for every 300 elective oophorectomies. If the ovaries are removed, the patient can be safely placed on replacement hormone therapy for a few years. Others would argue that even after menopause, the ovaries still play an important role in hormone balance and should therefore be preserved. Even following menopause, the ovaries continue to secrete certain hormones, most notably testosterone and other male-type hormones. Possibly, loss of these, especially when ovaries are removed premenopausally, can lead to loss of libido and hypoactive sexual disorder. At least one recent study, however, has seriously challenged this idea. In premenopausal women, there is no doubt that the ovaries have a major hormone function, both female as well as male hormones, and oophorectomy obviously interrupts this. Replacement of not only female hormones, estrogen and progesterone, but also the male hormone testosterone, can help and is becoming more common. Side effects of male hormone replacement can, however, be problematic. Changes may include oily skin, acne, male pattern hair growth, and even voice changes. Now let us review some of the reasons, or indications, for hysterectomy. These include, in broad categories, uterine disease, cervical disease, and uterine prolapse. There are many different types of uterine disease, including heavy menstrual periods, or menorrhagia, painful menstrual periods, or dysmenorrhea, adenomyosis, fibroids, painful intercourse, or dyspareunia, and chronic pelvic pain. For uterine disease, hysterectomy is seldom the only treatment option. However, in many cases of benign disease, hysterectomy is a good treatment option and often is the only permanent answer. Whether or not a hysterectomy should be considered as an option depends to a large degree on individual biases and opinions, which are often difficult for a physician to judge. Some women are so tired of one of the problems mentioned above that they would accept nothing else but a hysterectomy. Others are horrified when the word hysterectomy is even mentioned. An open and frank discussion of all available treatment options is usually the best approach. It is usually best to first simply listen to what the treatment options are, then go home and think it over for a while. Rash decisions are certainly not a good idea. Menorrhagia is one of these areas where hysterectomy is an excellent treatment option, but by no means the only one. There are many studies showing that with long-term follow-up, patients who choose hysterectomy for their treatment of menorrhagia were very satisfied. It is, after all, the definitive treatment for excessive menstrual bleeding and is the only treatment that carries a guarantee of success for this indication. Alternative treatments for menorrhagia include less invasive treatments like medications, including the birth control pill, and endometrial ablation or destruction. In the last decade or so, endometrial ablation has become very popular since it is a much less invasive procedure than a hysterectomy. Unfortunately, not everybody is a candidate for this procedure. Vaginal hysterectomy is successful for painful menstrual periods only if the pain is definitively shown to be related to the menstrual cycle and localizes only to the uterus. It is also the most aggressive treatment option for this indication, and there are some less invasive options. Painful menstruation can be related to a large number of conditions, and there is always some danger of continued pelvic pain even after hysterectomy. Adenomyosis is a condition involving ingrowth of glands into the uterus muscle, where it undergoes monthly swelling under the influence of hormone changes. This swelling and associated secretions can cause intense pain. Adenomyosis is difficult to impossible to diagnose preoperatively, and in cases where hysterectomy was performed for dysmenorrhea or dyspareunia, the first indication is often the pathology report. Fibroids are a common reason for hysterectomy. In fact, they are currently one of the most common indications in the Western world. Fibroids are true tumors developing from a single mutated uterine muscle cell. They are always benign or non-cancerous, but can grow to enormous size. Fibroids may interfere with bladder, bowel, and/or reproductive function. They may also cause menorrhagia, or heavy periods. And they may also present as a pressure feeling or even a visible mass in the lower abdomen. Vaginal hysterectomy can only be done for a uterus below a certain size. This size will somewhat depend on individual surgeons, but it is safe to say that few gynecologists will agree to attempt a vaginal hysterectomy for a uterus that is easily palpable above the pubic bone. For chronic pelvic pain, hysterectomy is a common practice. Unfortunately, it is always very disappointing when a patient continues to have pain after such an invasive procedure. Therefore, significant care needs to be taken in the investigation stage to confirm that the pain and/or painful intercourse is directly attributable to the uterus. Traditionally, one of the most common indications for vaginal hysterectomy was severe dysplasia, meaning abnormal cells, of the cervix or very early cervical cancer. Dysplasia is considered a precancerous state. Vaginal hysterectomy is the ultimate definitive procedure for these conditions, since removal of the cervix cures the problem. New developments in the treatment of cervical dysplasia and very early cervical cancer, such as cryotherapy, laser therapy, electroresection, or cone biopsies, have made hysterectomy a much less common treatment, although it is still an excellent treatment for those who have completed their family. Uterine prolapse is one of the most common indications for vaginal hysterectomy. A normally positioned uterus lies on top of the bladder in the standing woman. Although there is normally some movement of the uterus and cervix up and down in the vagina during activities and straining, this movement is checked by certain support systems. These are discussed in detail in a separate module. In this image, the main support structure for the uterus, the uterosacral ligaments, can be clearly seen. This image shows how the uterosacral ligaments have torn off, allowing the uterus to slip down into the vagina. As it starts its descent, the axis changes from horizontal to the erect position to the vertical. Gravity and pushing from above, from the weight of bowel, intra-abdominal fat, breathing, straining, etc., will complete the descent in time, often causing first the cervix and eventually the entire uterus to come right down through the vagina. The most common treatment for uterine prolapse is vaginal hysterectomy. The question is asked more and more, however, whether it is necessary. Most authorities do agree that for significant uterine prolapse with a completed family, removal of the uterus, usually vaginally, is appropriate treatment. It is extremely important, however, that the operation include a procedure to repair the defect that led to prolapse in the first place. Simply removing the uterus does not effect such a cure, and future vaginal prolapse will be more likely. Various procedures can be used along with the hysterectomy to support the vault or top part of the vagina. Uterine prolapse is almost always associated with other pelvic floor defects as well. These will require individual attention to each defect and a surgical approach correcting each. Depending on your medical condition and age, you may require a preoperative consultation with another specialist. You should make the necessary arrangements to allow you a stress-free recovery after your surgery. You should not have to worry about the kids, your work, your house, or the other usual responsibilities after your operation. These things should be arranged before the date of your surgery. Have a plan and arrange to have help. You will not be in a good position to cope with your normal responsibilities following surgery. The few days before surgery should be spent getting these final things in order and getting lots of rest. You'll need plenty of energy after your surgery. This energy will be required for healing, and it is very important. Please don't arrive at the operating room worn out by work, sport, or other endurance activity, be it physical or mental. Arrive as fresh and rested as possible. Start to cut down on solid food a few days before the operation. Soups, broths, or other soft foods will help to prevent bowel-related accidents in the operating room, as well as postoperative bowel difficulties. Some surgeons may prescribe enemas or oral medication to empty your bowels before surgery. The night before the operation, you'll need to completely stop all oral intake. Your surgeon or the preoperative clinic will let you know when. Try to arrive in ample time to cut down on the stress. Bring a book and relax. Realize that the estimated time of your surgery is just that. From the preoperative area, you'll be taken to the surgical suite waiting area before the procedure. Most likely, you'll be met by the nurses that will be responsible for your care, as well as the anesthesiologist. These people will ask you many questions and will have lots of paperwork to complete. Have patience with them. While nobody likes more questions and paperwork, it really is for your safety. From here, you'll be escorted to the surgical suite. In some institutions, you may be asked to walk there by yourself. In others, you'll be taken by wheelchair or on a stretcher. Vaginal hysterectomy can be done under either spinal or general anesthetic. It often depends on what you prefer. If you prefer to be awake, it is a good idea to bring some earphones and a music player of your choice. At the time of hysterectomy, other procedures are often required, depending on the situation. The need for these should be recognized before surgery and discussed with you so that your surgeon may proceed with the repair. These procedures include vault suspensions, enteroceal repair, anterior repair, posterior repair, an anti-incontinence procedure, and a perineal body repair. The recovery after a vaginal hysterectomy is usually much easier than after abdominal hysterectomy. There is no painful abdominal incision to limit physical activity, and the pain is usually significantly less. As a result of the lesser amount of pain, patients move around better and breathe easier, which results in a decrease in many postoperative complications, such as blood clots or lung problems. Most patients can be discharged home one day after an uncomplicated vaginal hysterectomy. In some places where adequate postoperative care is available, patients may even be discharged on the same day. The exact discharge time depends, however, on individual characteristics, including age, other medical conditions, or other issues such as pain control, urinating ability, or postoperative care issues. Individual perception of pain is highly variable, and the degree of pain one might experience is unpredictable. In general, vaginal hysterectomy pain decreases quite rapidly postoperatively. Typically, the postoperative recovery period following vaginal hysterectomy is about 6 weeks. For some people, this will not be enough, whereas others may feel almost completely recovered after 3 to 4 weeks. It is a good idea to allow yourself enough time to recover, since you will probably find that you are a lot more tired than expected. Sexual activity should be avoided for 6 weeks, to give the vaginal incision enough time to heal completely. Vaginal hysterectomy can be done under general anesthesia or spinal anesthesia. The latter allows the patient to be awake and generally makes for an easier recovery after the operation. Neither method is risk-free, although modern anesthesia is exceptionally safe. Anesthetic risks can be discussed with your anesthesiologist before surgery, and these are reviewed in separate modules. Bleeding or infection are 2 possible complications of any operative procedure. For vaginal hysterectomy, this is no different. Bleeding may occur either during the operation or later afterwards. Delayed bleeding may involve visible bleeding coming out of the vagina or internal bleeding, either into the abdominal cavity or into tissue, leading to what is called a hematoma. These two situations can be treated conservatively, or they may require reintervention. Infection can occur in any wound or incision. Hysterectomy, whether vaginal or abdominal, is complicated by the fact that an incision is made through the vagina, which is by no means a completely sterile area. Such infection may take the form of tissue infection, treated with antibiotics, or an abscess, which is a collection of pus that may require intervention for drainage. A laparotomy is when the abdomen has to be opened and inspected. This may be required to stop bleeding, drain infection, or repair other injury. Anytime surgery is done close to another organ, there is the potential for injury to that organ. This is especially true in hysterectomy, since the uterus is intimately associated with the bladder, the ureters, or urine drainage tubes, and the rectum. All of these organs are not only in close proximity, but often are fixed together with scar tissue, requiring physically cutting them apart. Stitches are then placed to tie down blood vessels and attach the vagina to supporting ligaments. These sutures need to be placed deep enough to do what they are supposed to do, but not through any of the above-mentioned organs. A suture may catch one of the organs and cause an injury that may present as bleeding, a tear in the organ, or a delayed complication like infection, or a stone in the bladder, or a fistula, which is an abnormal connection between two organs that are not normally connected. Injury to the ureters may obstruct them and can lead to kidney damage if not corrected. Any of these complications may cause a need for future interventions to correct the problem. Late complications may also occur following vaginal hysterectomy. As already mentioned, injury to organs in the area may lead to fistula formation, stricture of the ureter with complete or partial obstruction, or stone formation in the ureter or bladder. These are certainly unfortunate complications to develop, but they are really quite rare. Other late complications include further vaginal prolapse, vaginal shortening, and sexual problems. Prolapse, or downward displacement of organs into the vagina, as a complication of vaginal hysterectomy, usually happens years afterwards. It may be due to technical factors, lifestyle issues, or congenitally weak tissues. Vaginal shortening is universally present after hysterectomy. It simply cannot be avoided. It can, however, be minimized if care is taken to the point that most women will not even notice it. Excessive trimming of vaginal skin during vaginal repair procedures that are often done at the same time as hysterectomy may, however, lead to significant shortening. In spite of all possible care taken, there is always the possibility of the vagina being too tight, too loose, or too short after such procedures. Sexual function may also be affected if the vagina is shortened or narrowed following surgery. Most large studies have found, on average, a significant improvement of sexual function after hysterectomy, both vaginal as well as abdominal. This makes sense since the reason for hysterectomy by itself often interfered with a satisfying sex life. As long as the ovaries are not removed, there is usually no change in libido or sex drive. Most women having vaginal hysterectomy bounce back extremely quickly. Most are walking around the same night, depending on how early in the day they were done, and many have their bladder tubes or catheters taken out on the first night or early the next morning. Almost every patient will be able to eat the first night. As mentioned, in some institutions, patients are even sent home on the same day. The perception of postoperative pain is highly variable. Moreover, every physician and institution will have its own particular protocol. In many patients, the pain can be managed with simple oral painkillers, usually containing some form of opiate like codeine or oxycodone. Occasionally, If you have a spinal anesthetic, you may receive some form of morphine in the spinal anesthesia that works for almost 18 hours. PCA, or patient-controlled analgesia pumps, are used in some patients. Anti-inflammatories are also commonly used, in fact, sometimes alone, and they are very useful and effective. Hospital stay will vary from no overnight stay at all to a few days in hospital, depending on the details of surgery, the institution, the community resources available, patient expectations, and individual response. Most patients are given about 6 weeks to fully recover. It is important not to strain the pelvic floor too soon for fear of causing support procedures to fail. Heavy lifting, penetrative intercourse, contact sports, and heavy impact exercises are all definite no-nos for 4 to 6 weeks as an absolute minimum. Sedentary work may be resumed before this, but early on, many women will find that their ability to concentrate is a bit limited. It is better to ease back slowly if you plan to go to work before the 6 weeks. In summary, vaginal hysterectomy is often the preferred treatment for conditions of the uterus. Recovery is usually quick. Discharge is sooner than with abdominal hysterectomy, and complications may be less. Many women are surprised about how quickly they recovered from their vaginal hysterectomy. For the right indication, a vaginal hysterectomy can lead to a significant improvement in overall quality of life. These references are available from your local medical library for a more thorough review. We hope that through this presentation, you have gained a greater understanding of vaginal hysterectomy. We wish you the best for the future, and thank you once again for viewing this educational program.